Hello, my name is Rachel Sussman, and I'm a urologist at MedStar Georgetown University Hospital. Along with my co-authors, I'd like to thank the British Journal of Urology for highlighting our article, Guidelines of the Guidelines, Urinary Incontinence in Women, as Article of the Month. In this article, we review guidelines for the diagnosis and treatment of urinary incontinence in women from 5 major organizations. Guidelines are not exhaustive, but rather serve as a practical review of evidence-based management of index patients. All guidelines agree that physicians should perform a detailed history with a characterization of urinary incontinence, as well as a physical exam, including a pelvic exam, in all women with incontinence. The EAU, ICI, and NICE guidelines all recommend the use of avoiding diarrhea in any woman presenting with incontinence. American guidelines are less stringent, stating that avoiding diarrhea is optional. All guidelines agree that patients should have a urinalysis and that imaging and cystoscopy are not necessary in the evaluation of routine incontinence. All guidelines agree that checking a post-void residual can be useful, but only the ACOG and AUA stress urinary incontinence guidelines state that this should be done in all patients. All guidelines suggest a stepwise approach to the management of incontinence, starting with conservative therapy and moving to more invasive procedures as needed. For medical management of urgency incontinence, all guidelines recommend antimuscarinics. EAU guidelines recommend first trying conservative therapy, whereas all other guidelines state that these can be used as first or second line treatment. Both EAU and AUA guidelines state a preference for the extended release formulation due to lower rates of dry mouth and also caution the use of these medications in the elderly. All guidelines state that beta-3 agonists may be used as initial treatment for urgency incontinence, but NICE guidelines specifically recommend their use only if anticholinergics cannot be used. There are some clear differences in the guidelines when it comes to the surgical management of stress urinary incontinence. All concur that a midurethral sling is a viable treatment option, but NICE guidelines specifically state that the transobturator sling should not be used unless there are specific clinical circumstances such that the retropubic space should be avoided. For retropubic midurethral slings, while other guidelines review data on top-down versus bottom-up approach, NICE guidelines are the only ones to officially recommend against the top-down approach based on lower rates of subjective cure and higher rates of voiding dysfunction. All guidelines concur that an autologous fascial sling is a viable option. Barring clinical circumstances necessitating the use of either sling, NICE guidelines state a preference for the fascial sling, whereas ACOG guidelines state a preference for the midurethral sling. While most guidelines state that a single incision sling may be offered so long as patients are warned about the lack of long-term data, NICE guidelines state that these slings should not be used outside of a clinical trial. ICI and NICE guidelines are the only ones to include artificial urinary sphincter as an option for women with complicated stress urinary incontinence. While there are some nuanced differences between guidelines, for patients with urgency incontinence refractory to conservative and medical therapy, all guidelines are in agreement that intradetrusor chemodenervation or sacroneuromodulation may be offered, with augmentation cystoplasty and urinary diversion as a last resort. We hope this video has provided a brief overview of our findings, and you will read our paper for a more detailed discussion of the differences between guidelines.